Good afternoon, everyone. My name is Katie Abel, and I'm excited to share with you today how we are working to improve the lives of patients with invasive lobular carcinoma, or ILC, of the breast. Now, if there's one thing I want to leave you with today, it's this. ILC is a unique cancer without a unique management strategy. ILC grows in a different pattern than the more common invasive ductal carcinoma, which leads to decreased detection and higher stages at presentation. These patients are also underrepresented in major clinical trials, which puts them in a difficult situation because they're often getting treated with interventions that are studied predominantly in invasive ductal carcinoma. This may contribute to the poor clinical outcomes that we see in these patients. Thus, our broad research goal is to investigate the efficacy and clinical outcomes of standard interventions in ILC patients. And today, I'll discuss one of these surgical outcome studies with you all. One of the most controversial questions in the field of breast cancer is whether to perform an axillary dissection, which is the removal of 6 or more lymph nodes. Now, in the past, any patient with cancer in their nodes got an axillary dissection, but this is a morbid procedure with high rates of chronic pain and debilitating lymphedema. 2 randomized trials have shown that radiation can actually replace axillary dissection with less morbidity in patients with limited nodal involvement. However, ILC patients represented only 10% of the population in these trials, so we sought to evaluate the impact of axillary dissection on recurrence-free survival in patients with ILC. To do this, we performed a cross-sectional retrospective analysis in our institutional cohort of patients with ILC who did or did not have an axillary dissection. We used a Cox proportional hazards model, and our primary outcome was recurrence-free survival at 5 and 10 years. We used a multivariate analysis in our cohort and found no benefit of axillary dissection on recurrence-free survival, particularly in those with 1 to 3 positive nodes, where the current controversy exists. Outcomes in that subgroup are shown in the Kaplan-Meier curve on the right, confirming no benefit of axillary dissection. So to summarize, we found that axillary dissection in patients with ILC and limited nodal involvement is not associated with improved recurrence-free survival. But axillary dissection is not the only thing that's been understudied in ILC. We have a number of exciting projects that are underway with the common goal of understanding this unique disease. I want to thank my mentors and collaborators on this project, particularly Dr. Rita Mukhtar, as well as the year-long inquiry program and the School of Medicine. Thank you very much for listening.